So this is chapter 57, the assessment of the renal and urinary system. In this chapter, we are going to be reviewing some of the things that you learned in anatomy and physiology. We are also going to be reviewing some of the things that you learned in your Med-Surg 1 course. Go ahead and take a moment to review this slide. It is pertinent that you understand what your urinary and renal system look like. You do not necessarily have to know what the inside of the kidney looks like and every single working inner function of your kidney, but you do need to understand the purpose of each part of your urinary and renal system. Let's go ahead and do our assessment. So the first thing that we're going to look at is demographic information. Age, sex assigned at birth, race, and ethnicity is important to consider as a non-modifiable risk factor in the patient with any kidney or urinary elimination problem. A sudden onset of hypertension in patients older than 50 years suggests possible kidney disease. In men older than 50 years, altered urine patterns can also accompany prostate disease. Anatomic differences according to sex assigned at birth make some disorders worse or more common. Males rarely have urinary tract infections, for example. Females have a shorter urethra and more commonly develop cystitis because bacteria pass more readily into the bladder because of that shorter urethra. Modifiable risk factors, as well as socioeconomic status, level of education, language, and health beliefs, should be considered when assessing renal function. Socioeconomic status may influence healthcare practices. Prevention, early detection, and treatment of kidney or urinary problems may be limited by inability to access healthcare, lack of transportation, insufficient or no health insurance, and/or reduced income. These barriers contribute to inequity in healthcare and may result in difficulty adhering to a plan of care, having prescriptions filled, following dietary instructions, and keeping follow-up appointments. Educational level may affect health-seeking practices and the patient's understanding of a disease or its symptoms. Recurring urinary tract infections can result from not completing a course of antibiotic therapy or from not following up to ensure that the infection has even cleared. The language used by patients may be different from that used by healthcare professionals. When obtaining a history, listen to and explore the terms used by the patient. By using the patient's own terms, you may be able to provide a more complete description of the problem and may decrease the patient's discomfort when discussing bodily functions. The patient's health beliefs affect the approach to health and illness. Cultural background or religious affiliation may also influence the belief system, as well as overall comfort when discussing elimination. Ask the patient about previous kidney or urologic problems, including tumors, infections, stones, or urologic surgery. A history of any chronic health problems, especially diabetes or hypertension, increases the risk for development of kidney disease because these disorders damage kidney blood vessels. Ask the patient about environmental, food, or medication allergies. Exposure to certain contrast media during imaging can harm the kidneys. Iodinated contrast medium used for CT scans is associated with both acute and chronic kidney injury. Ask the patient about chemical exposure at the workplace or with hobbies. Just to touch back on the CT scans, whenever you guys have a patient who is going for a CT scan with any kind of contrast, usually they will fill out paperwork prior, and that will ask them if they have any history of kidney disease or impaired kidney function for this reason. For nutrition history, we're going to ask about food and fluid intake. Assess how much and which types of fluids the patient drinks daily, especially fluids with a high calorie or caffeine content. Use this opportunity to teach the patient the importance of drinking sufficient fluid to cause the urine to be dilute. This is going to be like a clear or a light yellow. If another medical problem does not require fluid restriction, ingestion of about 2 liters of fluid daily is recommended. Ask about any changes in appetite or taste. These symptoms can occur with the buildup of nitrogenous waste products from kidney failure. Changes in thirst or fluid intake may also cause changes in the volume of urine elimination. For our medical history, we are going to identify all of the patient's prescription drugs because many can impair kidney function. Ask about the duration of drug use and whether there have been any recent changes in prescribed drugs. Drugs for diabetes, hypertension, cardiac disorders, hormonal disorders, cancer, arthritis, and psychiatric disorders are potential causes of kidney problems. Antibiotics such as gentamicin may also cause an acute kidney injury. Drug-to-drug interactions and drug-to-contrast media interactions also may lead to kidney dysfunction. You're going to explore the past and current use of over-the-counter drugs or agents, including dietary supplements, vitamins, minerals, herbal agents, laxatives, analgesics, acetaminophen, and NSAIDs. So one of the things I want to touch on with NSAIDs. So whenever you think of acetaminophen, if you take too much of it, it's going to cause liver problems. We all know Tylenol can cause the liver problems if it's ingested too much. What people don't know is those NSAIDs, N is nephro in this case, okay? So NSAIDs can cause damage to your kidneys if you are over consuming them. This includes things like ibuprofen, Motrin, or Excedrin. Many of these agents affect the kidney function and the urine elimination. For family history and genetic risk, the family history of the patient with a suspected kidney or urologic problem is important because some disorders have a familial pattern. Ask whether siblings, parents, or grandparents have had any kind of kidney problems. And then our current health problems. The effects of kidney failure are seen in all body systems. Document all of the patient's current health problems. Ask the patient to describe all health concerns because some kidney disorders cause problems in other body systems. Recent upper respiratory infections or any problems, aching muscles or joints, heart disease, or GI conditions can be related to problems with your kidney function. We are going to assess the kidney and urologic system by asking about any changes in the appearance, such as color, odor, clarity of the urine. We are going to ask about the pattern of urine elimination, ability to initiate or control voiding, and any other unusual symptoms. Urine typically has a mild but distinct odor of ammonia. An increase in the intensity of color, a change in odor quality, or a decrease in urine clarity may suggest an infection. Ask about changes in urination patterns such as incontinence, nocturia, urgency, frequency, or an increase or decrease in the amount of urine. The normal urine output for adults is about 1,500 to 2,000 milliliters a day, or within 500 milliliters of the volume of fluid ingested daily. Ask about how close the urine output is to the volume of fluid ingested. Ask whether initiating a urine flow is difficult, a burning sensation, or other discomfort occurs with urination, the force of the urine stream, ask if it's decreased, or persistent dribbling or leaking of urine is present. Continue on with our assessment. For our physical assessment, the physical assessment of the patient with a known or suspected kidney disorder includes general appearance, a review of body systems, and specific structure and functions of the kidney and urinary system. Assess the patient's general appearance and check the skin for any presence of rashes, bruising, or yellowish discoloration. The skin and tissues may show edema associated with kidney disease, especially in the pedal, pretibial, or sacral tissues. That's going to be like the pedal area is going to be your foot, and pretibial, think that pre is going to be in front. That's going to be the front of your shin, and then the sacral tissues and around the eyes. Use a stethoscope to listen to the lungs to determine whether any fluid is present. Think, what are we going to hear whenever fluid is present on the lungs? If you thought crackles, you are correct. It's going to sound kind of wet. The patient may be struggling to take a good deep breath. You're also going to weigh the patient and measure blood pressure as a baseline for later comparisons. One way we do that, think about daily weights. It's going to tell us if we're gaining any kind of fluid weight because the kidneys aren't excreting urine like they're supposed to. We are going to assess the levels of consciousness and alertness. Think if you're having any kind of toxic waste backup in the blood. It can really go to your head, it can go to your brain. You may not be exchanging oxygen adequately in your brain, and we might start to show some confusion. We are going to record any deficits in memory, concentration, or thought processes. Family members may report subtle changes. Cognitive changes may be the result of buildup of waste products when the kidney disease is present. So let's go ahead and talk about our diagnostic assessments. We're going to go ahead and start with these blood tests. So whenever we're doing blood tests, we're going to be looking at creatinine levels, BUN levels, and a BUN to serum creatinine ratio. So creatinine is a waste product of protein or muscle breakdown. The level of creatinine in the blood is an indication of the kidney's ability to excrete waste. Serum creatinine is elevated only in renal disorders. It does not increase until at least 50% of renal function is lost, so any elevation is going to be important. It's also a better measurement of kidney function than BUN is. Unlike BUN, creatinine is not influenced by diet, hydration, nutritional status, or liver function. With normally functioning kidneys, the serum creatinine level varies with age, gender, body muscle mass. Levels slightly higher in men than women because of that larger muscle mass. An increased level is going to indicate a renal impairment. A decreased level may be caused by a decrease in muscle mass. If you have an elevated serum creatinine, ask do they take any non-prescription medication or supplements such as vitamins or aspirin, Advil, or Aleve. Those should sound familiar because they're NSAIDs. And remember, N for NSAIDs, N is going to affect your nephros. Your blood urea nitrogen, that is going to be your bun as in hamburger bun. That's going to be a bun test. It is a general indicator of the kidney's ability to excrete urea nitrogen. This is going to be an end product of protein metabolism in the liver. The liver must be functioning properly to produce the urea nitrogen. If the liver is dysfunctional, urea production is limited. Kidneys filter waste from the blood and excrete waste in the urine. Bun is not always elevated with kidney disease and is not exactly the best sole indicator of kidney function. Your bun is going to be influenced by diet, hydration, nutritional status, liver function, and/or rapid destruction of red blood cells. In addition to renal failure, factors that can increase bun are a high-protein diet, especially with renal disease, gastrointestinal bleeding, dehydration, and some drugs such as aspirin, chemotherapeutic agents, diuretics, gentamicin, remember that's an antibiotic, morphine, steroids, sulfonamides, and tobramycin. Moving on, we have our bun to serum creatinine ratio. So this is going to be a comparison between these two waste products. Your kidneys help get rid of both, so we're going to use these to check to see how well your kidneys are working. So the bun to creatinine ratio is going to help us figure out what is causing a kidney's problems. A normal ratio is 10 to 20. If it is higher than 20, you might be dehydrated or have something else affecting the blood flow to your kidneys. Whenever it is high, above 20, think high can be dry, okay? So dry is dehydrated. Higher than 20 is dehydrated. A normal or low ratio indicates that there might be a problem actually inside the kidneys. It's not something else causing that ratio to be off. You can actually find on page 1393 what these labs indicate and what the normal labs are. Moving forward, we have our urine test. So one of the most common things is going to be a urinalysis. This is going to be collected at the morning's first voiding. Other times it may be too dilute. The color should be pale yellow. The odor should be a slight ammonia smell with no turbidity, so it should be clear. Specific gravity, when we are talking about a urinalysis, this is going to measure the density or concentration of urine as compared to the water. So water has specific gravity. The specific gravity is 1.000. A normal value for a specific gravity in the urine is 1.005 to 1.030. Value is going to decrease with age due to the decreased ability to concentrate urine. An increased specific gravity indicates concentrated urine due to dehydration, decreased kidney blood flow or stress, surgery, and some medications such as anesthetic drugs, morphine, or oral diabetic medications. A decreased specific gravity can indicate diluted urine that may be due to high fluid intake, diuretic drugs, or diabetes insipidus. For RPH, it is going to measure the urine's acidity or alkalinity. If it is less than 7, it is acidic. If it is greater than 7, it is alkaline. This can be influenced by diet, such as high fruits or vegetables. Those can cause alkaline. A diet high in protein can be more acidic. For the presence of E. coli, this is going to happen in more acidic urine. Urine specimens become more alkaline when 1, they are left unrefrigerated for more than an hour, 2, they have the presence of bacteria, or 3, it is an uncovered specimen. Therefore, specimens should be covered, refrigerated, and delivered promptly. For protein, protein is not normally present in the urine. Proteinuria may indicate infection or possible kidney damage. For glucose, when the blood glucose level gets above 220, the renal threshold for reabsorption is exceeded and glucose is going to be present in the urine. Patients with infection or diabetes, glucose in the urine can even be found if the blood glucose is normal. For ketones, these result of an incomplete metabolism of fatty acids. This is when fat is used instead of glucose for cell energy, and it's not normal in urine. And then we have leukoesterase. This is going to be the enzyme in white blood cells. These are also not normally in urine. This is how they check to see if you have a UTI. Nitrates is just a chemical, plus the finding equals a UTI. Culture sensitivity, it must be sterile, and you're going to collect a culture and sensitivity by a clean catch or a catheter. So think about who you would do a urine culture and sensitivity on. Usually we do this in patients who have a UTI that may be resistant to treatment. So we are going to take a sample of the urine and let the bacteria from it grow. Then we are going to test that bacteria to different antibiotics to see which ones it is sensitive or resistant to. We may then prescribe an antibiotic to see, or we may prescribe an antibiotic that the bacteria is sensitive to, so we know that that antibiotic is working. For urine collection, for a 12 or 24-hour collection, you guys can actually see under composite urine on page 1396. We are going to do a 24-hour urine collection, and to do that, you are going to have the patient void, and you are going to discard that urine and mark the time. That time is when it starts, because it's going to start on that empty bladder. You will then collect urine in a jug for the next 24 hours or however long the time is specified. And remember, you want to keep that urine on ice or refrigerated for it to be relevant, for it to be accurate. Okay, I'm going to go ahead and actually separate this into another part. So this is going to be part 1. So this is part 2 of this slide. If you have not already, go ahead and go back and listen to the first recording and then come back to this one. But to pick up, let's talk about creatinine clearance. This is calculated measuring of the GFR. It is specifically going to estimate how much blood passes through the tiny filters in the kidneys each minute. This is usually done with a 24-hour urine and it is the best indicator of overall kidney function. So the calculation is going to compare the urine creatinine level to blood creatinine level, so a blood specimen must also be collected. If you have a low GFR, you are at risk for fluid overload. We are also going to avoid NSAIDs if you have a decreased GFR because we're going to prevent further damage to the kidneys. Regarding urine electrolytes, we are going to analyze electrolyte levels in the urine. As far as sodium goes, normally the amount of sodium excreted is also the amount of sodium consumed. We want to make sure that we're not retaining any sodium. Moving on to our imaging assessment. So if you guys look at the picture on the slide, this is a bladder scanner. It is going to be your best friend if you are ever suspecting that somebody is retaining urine in their bladder. So for the bladder scanner, this is a non-invasive method of measuring urine volume, usually for a post-void residual portable ultrasound. So that post-void residual, that means we're going to have them use the bathroom, and then we're going to scan their bladder to see if they are emptying their entire bladder. We are going to use these to determine the need for intermittent catheterization based on the amount of urine left in the bladder, not the time between caths. There's also an image on page 1391. This is the type of bladder scanner that Southwell used up until recently. We are going to use these bladder scanners to choose male or female. We are also going to use the male icon when a woman has had a hysterectomy. We are going to use conducting gel. We are going to place the scanner above the pubic bone, and it is going to beep when it is complete. You will hold the button, you will roam over the person's bladder, and the bladder scanner will tell you how much fluid is in there. You might get an inaccurate reading on someone who is pregnant just because they have that extra fluid in their abdomen. We always recommend that you use 2 readings and don't just go off your first one. Next, we have a KUB. This test identifies the shape, size, and relationship of the organs to other parts of the urinary tract. Remember, a KUB is kidneys, ureters, and bladder. For a CT, this is going to measure the kidney size, and it is going to assess for masses, stones, trauma, metastasis disease. It is going to give us 3D information. The patient may be ordered to be NPO, although it's not common. The doctor may order contrast to be used. We are going to assess for allergies. Some people are allergic to that contrast dye. But this test is going to allow your doctor to look at your urinary system using that special dye, which is a contrast medium, and it's going to show up on an X-ray. The dye may be injected into one of your veins or by mouth. Some people have to just drink the dye. And it's going to travel through your bloodstream, kidneys, ureters, and bladder before being passed out into your urine. The dye helps to show your urinary system more clearly than any ordinary X-ray. Your doctor will be able to see how quickly and efficiently your urinary system is working and how well it's dealing with fluid and waste. Bowel prep, allergy, NPO, or clear liquids, you can have any of these. You're just going to go by the doctor's order. If you are using metformin, other name is glucophage, this should be discontinued for at least 24 hours before the procedures and for 48 hours post-procedure due to lactic acidosis, okay? You can cause somebody's kidneys to fail if you are giving them metformin and that contrast. So make sure if you are ever giving someone contrast when you're doing screening for a CT, make sure that you know if they are diabetic, if they have any previous kidney disease, and if they are taking metformin. After the procedure, make sure that your patient is drinking plenty of fluids to help flush the dye out of your system faster. For ultrasonography, we are going to put our patient in a prone position with a full bladder, and those sound waves are going to reproduce images. This can help us identify masses, obstructions, and tumors. Renal arteriography, this is also called an angiography. This is when a catheter is placed through the femoral or the axillary arteries and into the renal artery or aorta, and then contrast will be injected. Angiography evaluates renal blood flow in trauma, tumors, and elevated hypertension. Pre-procedures, laxatives are given, the injection site is prepped, pulses, femoral, pedal, and radial are going to be identified. We're going to identify these pulses prior to make sure we have adequate blood flow, and if we don't have those pulses afterwards, we might need to check into that. This test has mostly been replaced by other imaging tests such as renal scans, ultrasound, and CT, and it's rarely used as a standalone test. It's mostly used at the time of a renal angioplasty or other intervention. Continuing with our diagnostic assessment, so we have a cystography. This is going to be where we insert a catheter for dye installation. This is usually done for trauma or injury. And afterwards, we are going to monitor for infection and we are going to increase fluid intake. For renography, this is a kidney scan. A small amount of radioactive material is used and it is given in the IV. For a cystoscope, this is used to ID obstructions, and they may actually correct the obstructions while they're in there, and abnormalities of the bladder wall and urethral occlusions. The scope goes through the urethra and into the bladder, and they visualize the bladder with a lighted tube and instill dye to visualize the bladder on an X-ray. This requires a urinary catheter temporarily for dye instilled into the bladder, and X-rays are going to be taken. This is considered an operative procedure because they may remove bladder tumors, and it is also used for enlarged prostates. So voiding cystourethrogram, the patient is going to void and X-rays are taken during voiding to determine urine reflux into the ureter. For a renal biopsy, so explain that a kidney biopsy can help to determine a cause for unexplained renal problems and can help to direct or change therapy. Most renal biopsies are performed percutaneously, which is through the skin and other tissues, or using ultrasound or CT guidance. The client signs an informed consent and clients are NPO for 4 to 6 hours before the procedure. Because of the risk for post-procedure bleeding, coagulation studies such as a platelet count, a PTT, and a PT, and bleeding time are performed before surgery. Think about if your patient is on a new blood thinners, you may need to go ahead and stop those blood thinners beforehand. You would not be giving somebody a Levodox shot the morning that they are having a kidney biopsy. After a percutaneous biopsy, the major risk is bleeding from the biopsy site. So for 24 hours after the biopsy, we are going to monitor the dressing site, vital signs, urine output, hemoglobin level, and hematocrit. Even if the dressing is dry and there is no hematoma, the client could be bleeding from the site. An internal bleed is not readily visible, but it can be suspected with flank pain, decreasing blood pressure because think that blood's got to go somewhere, decreased urine output, or other signs of hypovolemia or shock. So how would you know if a patient is bleeding on the inside and you can't see blood? Think about the things that you would assess to determine that. The client follows a plan of strict bed rest, lying in a supine position with a back roll for additional support for 2 to 6 hours after the biopsy. The head of the bed may be elevated and the client may resume oral intake of food or fluids. After bed rest, the client may have limited bathroom privileges if there is no evidence of bleeding. Go ahead and take a moment to read the question, look over your answer choices, and select your choice. You can pause your video here. The answer to this question is D as in Delta. The ability of the kidneys to self-regulate renal blood pressure and renal blood flow keeps the GFR constant. A blood pressure of 92/48 is a MAP of 62. The kidney has difficulty regulating GFR with a MAP pressure less than 65. So go ahead and take a moment to read the question, look over your answer choices, and choose your answer. The answer here is going to be B as in boy. And we say this because high protein intake can increase the risk for renal calculi, which is kidney stones. And with a history of calculi, high protein shakes should be avoided. The nurse will provide additional education regarding this statement. All of the other statements are accurate. All right, so go ahead and take a moment to read your question, look over your answer choices. You can pause your video here. The answer to this question is D as in Delta. So the first two answer choices, digoxin and metoprolol, we don't have enough information from the question to really question these or read into them. For C, that urine culture for a temperature greater than 38.5 degrees Fahrenheit or Celsius, yeah, so that's kind of elevated, so we wouldn't mind getting a urine culture because there could be an infection, and we use urine cultures when we're looking at infections. For D, that ibuprofen, remember ibuprofen is an NSAID. NSAID, N and nephro go together. So we are not giving people who have kidney problems NSAIDs if we can avoid it. Go ahead and take a moment to read the question and look over your answer choices. You can pause your video here. The answer here is going to be 3. So serum creatinine measures the amount of creatinine and it indicates renal function. A normal serum creatinine is 0.8 to 1.6, and remember, we're not going to see changes until about 50% of the kidney function is compromised, so any elevation is important. Urinalysis is a gross and microscopic view of urine that can indicate such disorders as a UTI or dehydration. The specific gravity of 1.015 is within the normal limits. Urine culture specifically examines the type and amount of microscopic organisms present in the urine, and it should be negative. Serum potassium may be increased in renal failure as well as other disorders, so it's not a definitive diagnostic test for renal function. But anyway, the value here is normal. It's 3.8, and a normal potassium is 3.5 to 5.